Hi, I'm Dr. Stuart Goldberg. I'm the Chief Medical Officer of a data analytics company known as CODA, and I'm also a member of the Division of Leukemia at the Theurer Cancer Center. As one approaches the end of life, we know that the cost of care rises dramatically. Most times, unfortunately, we spend more in the last 6 months of life than we do in our entire lifetime up to that point. But we also know that most patients, when they're interviewed, say that they really don't want the high technology end-of-life care that we're currently delivering. They don't want to die in a sterile environment in the hospital. And yet the patients don't bring that up to their physicians because they're fearful that it'll be looking like they're giving up. Likewise, we know that physicians rarely like to discuss end of life, and so both sides look at each other and no one asks the right questions. And so patients unfortunately end up getting expensive care that they really don't want. So multiple attempts have been tried to see how we can move that needle to get those discussions to occur, but these are often perceived as death panels and not very palatable to anybody in the field. At CODA, we took a different tact. We wanted to see if there was a way to get the patients to voice their concerns. So we developed a simple 7-question questionnaire that would be given to patients with metastatic disease that would assess their overall distress. It doesn't mention anything about end of life, but rather it asks questions that every doctor should be asking their patients with advanced disease. Are you able to function? Are you in pain? Are you burdening your family financially or time-wise? Are you feeling depressed? And what we noticed was as those patients became more distressed, as they answered those questions more in the affirmative, we saw that the patients, unfortunately, as they started to decline, the doctors also felt independently that those patients might be the ones that they would give a hospice-type consult. So in an initial pilot that we did last year of 400 patients, the more distressed patients were also independently thought by the doctors to be the patients that were appropriate for hospice. At this year's ASCO meeting, we extended our study to over 1,100 patients. And what we found is, once again, as the patients told us that they were more distressed in their own voice, we saw that unfortunately the survival started to go down. So we correlated how a patient felt and how distressed they were with what their overall survival would be. The implications of this are dramatic. If we could now take this information and do a survey with a patient and see if they're very distressed, we can tell the patient that when you become very distressed with a cancer, you might not live as long, and maybe we can deal with that distress in a different way, not by putting you in the hospital and giving you technologically expensive therapies, but maybe by dealing with the distress in a palliative care method. And this might then limit the cost of medicine for everyone, and at the same time, give the patients what they really are asking for.